You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 6, 2024. This week, some brief feedback on the ABYSS trial and beta-blockers, a more ESC recap, including the SHAM-PVI, FINEARTS-HF, and RESHAPE HF trial, and it will take a couple of weeks at least to recap all of the trials at the ESC meeting. First topic is some feedback on beta-blockers in the ABYSS trial. Recall that ABYSS was beta-blocker discontinuation at 1 year after MI in patients who had a preserved EF. The trial, which compared continuation versus discontinuation at 1 year, was positive-ish for the continuation group. But this positive finding was driven by increased hospitalizations in the discontinuation group, mostly for angiography. However, I opined that it was a positive trial for discontinuation because death and MI were not any different. Now, multiple emailers to me noted that there was no difference in quality of life scores in the ABYSS trial, and I'd kind of left that out. That is interesting and worthy of a comment because we all hear how bad beta blockers are for quality of life. Yet, discontinuation in the ABYSS trial did not cause an improvement in quality of life. Also, one of the senior authors of the REDUCE AMI trial emailed me to remind me that they also looked at quality of life in their trial and actually presented and published a quality of life paper in the European Heart Journal Cardiovascular Pharmacology. They found that the EQ5D, EQ-VAS, and WHO-5 questionnaires were similar between the randomized groups in REDUCE AMI. And remember that REDUCE AMI was beta blocker or no beta blocker after an MI and preserved LV function. So this lack of difference in quality of life seen now in two trials reminds me to mention that beta blockers may be one of the most nocebo-affecting drugs we use. Patient after patient will tell you in clinic that they feel terrible on beta blockers. And clearly, you cannot win the Tour de France if you're taking a beta blocker. It drops heart rate. And some patients clearly have symptoms, probably more on metoprolol than other beta blockers. But still, these sorts of data suggest that prior studies on placebo effect are probably real. Why, for instance, if beta blockers make people feel so bad, was there no difference in ABYSS when patients dropped the drugs in the open-label trial? Also, why did the no beta blocker arm of REDUCE AMI RCT not report better quality of life? I'm going to link to a fascinating study that I use in my clinic regarding nocebo effect of beta blocker and erectile dysfunction. The first author of this paper is Antonello Silvestri. It's in the European Heart Journal, 2003. I'll link to it. 96 patients with heart disease that were not suffering from erectile dysfunction, and they were placed on atenolol. Group A, the first group, 32 patients were told nothing about the drug. Group B, 32 patients were told about the drug, but not about side effects. And 32 patients were told that the drug could cause erectile dysfunction. And what do you think the incidence of erectile dysfunction was in the three groups? The incidence of ED in the told nothing group, just 3%. The incidence of ED in the told something group, 15%. The incidence of ED in the told about erectile dysfunction group, 31%. So my take home is that words can harm and words can heal. Use words wisely, especially around the use of drugs that have proven benefit. But here, after MI with preserved LV function, Based on the two trials, I think we can safely withhold beta blockers in the absence of some other indication. And also note that there are going to be more trials looking at no beta blockers versus beta blockers after MI in the modern era. Okay, first topic today is SHAM-PVI trial. This is a remarkable trial as it is the first proper sham-controlled trial for AFib ablation, despite the fact that we have done this procedure for over 20 years and in close to millions of patients. I would call those who said that we did not need such a trial incurious. Of course there is a placebo effect from AF ablation. When a patient with terribly symptomatic AFib pre-ablation returns to post-ablation clinic and that patient declares that you have changed his life because he feels so much better, but his ECG shows AFib, then ablation in that case is nearly 100% placebo. And this situation is not common, but it is also not rare. So, led by Dr. Rajeep Dulay from the UK and published in JAMA, the SHAM-PVI trial randomized 126 symptomatic persistent and paroxysmal AF patients to either a cryoballoon PVI or a sham procedure that involved femoral access and phrenic nerve pacing. Notably, 80% of the 67-year-old patients had persistent AFib, and so cardioversion was done for all patients in both groups who were in AFib at the time of the procedure. Also notable was that the time to ablation from the diagnosis of AFib was about 2 years, so these were not early AF ablation patients. All patients in the trial had a loop recorder before randomization, and this allowed the investigators to measure pre-ablation AF burden as well as the AF burden at 6 months. They also measured quality of life measures as well as time to event measures. The results were quite positive. Ablation versus sham resulted in absolute change in AF burden from baseline was 60% in the ablation arm versus 35% in the placebo arm, which was highly significant. All three quality of life scores improved significantly at 6 months in the procedure arm. Now, the blinding index results were interesting. Immediately after the procedure, there was near complete blinding, but after 6 months, the guessing of the treatment arm was much better, indicating the possibility that symptoms is just the way the patient feels the PVI or sham. So my comments on SHAM-PVI. The first thing to say, of course, is congratulations to the UK team. This is a remarkable achievement. They did it. And I believe that they have shown that, yes, AF ablation definitely has a placebo-resistant effect. The authors claim that there is no clinically relevant placebo effect, but I don't completely agree with that, and I'll come back to that statement. The first nuanced thing in this trial was the choice to measure AF burden. Now, we know that ablation will reduce AF burden versus sham or drugs or cardioversion. That's not in question. This would be like measuring the degree stenosis reduction in the Orbita PCI trial. We know that PCI reduces stenosis. We know that PVI reduces AF. The question I think we all want to know is whether symptom relief will be better in the active versus the sham arm. In fact, it was better in the active arm. But there are a few buts. These were highly symptomatic patients. The mean AF net score of 53 at baseline is quite low. My friend Dr. Dhiraj Gupta wrote to me that the mean score in Cabana was 63, and higher is better. So these were highly symptomatic patients. Dr. Gupta's group in Liverpool have shown that quality of life improvement following PVI is inversely proportional to the baseline AF QT score. So, by starting with a highly symptomatic group of patients with long-standing 2 years of AFib, they set the stage for improvements in quality of life. And that is all fine. I'm not criticizing the choice. But I'm merely pointing out that if we ablate early in the course of a patient, wherein they are less sure of their symptoms, there may be less of a delta between sham and procedure. SHAM-PVI reinforces the value in not ablating early. I point everyone to the improvement in the sham arm. Some of this is due to the cardioversion and antiarrhythmic drugs, as it is well known that AFib stays away in a small but substantial number of patients who we do a simple shock on. There is also a well-known regression to the mean, and there's a natural history of AFib. And I think what I'm about to say is the most important message from this week's podcast. The most important thing is that AFib often goes away on its own. There is a value in letting it happen if it will, of course, right? If AFib goes away on its own, you haven't exposed that patient to a procedure. In the absence of heart failure or decompensation, please, my friends, give peace a chance to heal AFib. Educate these patients, reassure them, be their psychologist, treat metabolic risk factors, cardiovert them, and see what happens. See if the AFib will go away. Now, my friend, Dr. Soren Dietrichson, sent to me by email that when you look at individual symptom scores by ERA classification, that is 1, no symptoms, 2, mild symptoms, 3, severe symptoms, 4, disabling symptoms, then there was only modest improvements in the scores. And look at tables E9 through 11 in the supplement. My final criticism is the lack of a transeptal in the sham arm. That they did not do this is totally understandable. I get it. It makes it ethically easier to do a sham trial. Transeptal punctures increase the risk to the sham arm, but there are clear effects on intraatrial hemodynamics to the atrium with the transeptal. And we should recall that the heart has its own intrinsic nervous system, and transeptals can perturb that, possibly in favorable ways. Now, I realize that this argument I'm making sounds soft, right? You think doing a transeptal does anything. And you might be right, but then please explain to me why many patients with reconnected pulmonary veins are cured of their AFib. My point is, there's a lot of things about AFib and AFib ablation that we don't understand. A transeptal in the sham arm may have narrowed the difference in the two groups. We don't know. So my conclusion is that SHAM-PVI is a large step forward. It's worth celebrating. It was a bold study. It was scientifically strong and the best trial of the year in electrophysiology, I think. But I don't think it closes the chapter on quantifying the placebo effect from ablation. There are 2 other ongoing sham-controlled trials, and we're going to learn more when we take them together as a whole. I worry that many of these have too cautious of a sham arm, but it is the reality. And a final note to the ethical naysayers. I mentioned the counterfactual of what if SHAM-PVI had been an orbita or simplicity 3 hypertension. In other words, what are the ethics of doing a quality of life procedure in millions of patients and it turns out to be mostly a placebo? SHAM-PVI-like trials should have been done sooner, in my opinion. They weren't because EP as a field has too much confidence and too little curiousness. All right, second topic is FINEARTS-HF, a trial of finerenone. Cardiologists are about to see more free donuts and burritos in their offices. The makers of the non-steroidal mineralocorticoid receptor antagonist finerenone has passed muster in a large cardiovascular outcomes trial in patients with heart failure with mostly preserved ejection fraction. The title of the FINEARTS-HF trial includes the word, quote, mildly reduced or preserved EF, but the mean LVEF in the trial was 53%, and only a third of patients in this trial had an EF between 40 and 50%. Nonetheless, heart failure with preserved ejection fraction, as everyone knows, is a difficult condition to treat. Proponents say we have some available treatments, but technically speaking, the sacubitril/valsartan Paragon trial was technically negative, as was the TopCat trial of spironolactone. And in Emperor Preserve, the reduction in heart failure hospitalizations was modest and only a small fraction of total hospitalization. My point is that, unlike HFrEF, where the 4 classes of GDMT have clear additive benefits in hard endpoints, patients with HFpEF garner a lot less benefit on average from these treatments. That's why FINEARTS-HF is so important. HFpEF is not only harder to treat, but also it's more prevalent than HFrEF. So here was the trial summary. 6,000 patients with class 2 to 4 heart failure and an EF more than 40%. One group gets placebo, the other group gets finerenone. Over 32 months, a primary endpoint of total heart failure events, first or recurrent hospitalization or urgent visits, and CV death occurred in 14.9 per 100 patient years in the finerenone group versus 17.7 per 100 patient years in the placebo arm. This was a 16% reduction with a hazard ratio of 0.84, confidence intervals 0.75 to 0.95, so statistically significant. The composite endpoint, however, was driven by an 18% reduction, hazard ratio 0.82 in heart failure events, but the rate of CV death was not statistically significantly different, 8.1 versus 8.7%. The results for the primary outcome were consistent across all pre-specified subgroups, including those defined according to baseline LV ejection fraction, less than 60 or greater than 60, and baseline use of SGLT2 inhibitors. As for secondary endpoints, the KCCQ quality of life score improved in both groups, but the delta was very small. So I think little effect on quality of life. There was also no differences in a number of patients who improved one class of New York Heart Association functional class. Death overall from any cause was not different. Total adverse effects were similar, but finerenone had more hyperkalemia, 3% versus 1.4%, though no episodes of hyperkalemia led to death. So my comments. There were many other papers around MRAs and finerenone published at the time of ESC. We already know that finerenone has two positive outcomes trials. Just briefly, the Fidelio DKD improved kidney outcomes in patients with CKD and diabetes. The hazard ratio for finerenone versus placebo in that trial was 0.82, and that was a composite of kidney failure, sustained decrease of eGFR by 40%, or death from renal causes. There was also in Fidelio DKD a secondary outcome of MACE, and it was lower in the finerenone group, but only by 1.8% in absolute terms. And then we also know that finerenone has the Figaro DKD trial. This was finerenone versus placebo in patients with CKD and diabetes. And this was a cardiovascular MACE as a primary endpoint, and a composite primary endpoint of Figaro was CV death, MI, stroke, or heart failure, and the hazard ratio was 0.81, and it was statistically significant. The absolute risk reduction, again, about 1.8%. Now, I am a huge fan of MRAs. I call them my secret weapon. The RALS trial of spironolactone for HFrEF shows one of the largest effect sizes in mortality reduction in all of cardiology. I think MRAs are underused and underthought about. So FINEARTS was a positive trial, though the risk reduction is modest in absolute terms and is driven solely by heart failure events, not CV death. Now, Jack has published a very nice paper this weekend from the heart failure trialist titled, quote, "Why have we not been able to demonstrate reduced mortality in patients with heart failure with mildly reduced or preserved ejection fraction?" And it's a long essay, but I think the gist of it is pretty simple. Patients with heart failure with a decent ejection fraction are typically older. They have more competing causes of death. A patient with HFrEF is sick because of the weak heart. A patient with HFpEF is sick with lots of things, and the diastolic dysfunction is only one issue. HFpEF, in fact, is a great condition for thinking about the domains that affect treatment effects. Think about it, the domains that affect the treatment effect. When we treat a patient with HFpEF, we have to think about opposing forces. One is the risk of the primary outcome versus the risk of a competing cause of morbidity. The other opposing force is the chance of treatment benefit versus the chance of treatment harm. In a young male HFrEF patient, a typical outpatient heart failure clinic patient, there is a high risk of the primary outcome. There's little chance of treatment-related harm, and there's minimal competing causes, and drugs are highly effective. But it's the opposite situation in an 80-year-old woman with hypertension, diabetes, CKD, arthritis, immobility, poor social supports, a high-salt diet, and this patient has recurrent heart failure admissions. Finerenone treats one of these many issues. And of course, it cannot reduce CV death because there are a blue million ways a woman like that could die. Now, the final issue with FINEARTS, the elephant in the room, is not how finerenone performs against placebo, but how it would perform against spironolactone. The design of the FINEARTS-HF with a comparison against placebo makes the assumption that the TOPCAT trial of spironolactone and HFpEF was totally negative. Because if you assumed TOPCAT was positive, then you would have to study finerenone against the established standard, which should be spironolactone. But yet everyone knows the TOPCAT story that if 2 countries were excluded, spironolactone definitely has a beneficial effect in these patients. So what a typical clinician today, tomorrow, the next day, wants to know is finerenone versus spironolactone. That would be the trial. Because the question is not whether MRAs reduce heart failure events in HFpEF, but is finerenone superior to the far less expensive spironolactone? I suspect that it will be marketed as having less steroidal side effects and less hyperkalemia, and that's probably true. But should we not go first with spironolactone and see how it is tolerated? I'm truly asking the experts here. Feel free to weigh in, but to me, it seems like finerenone is a MRA. It's beneficial. TOPCAT really looked beneficial with spironolactone. Spironolactone is less costly, inexpensive, and should we not try that first and reserve finerenone for patients who don't tolerate spironolactone? People disagree, feel free to chime in. All right, final topic is the RESHAPE HF trial. At ESC, we learned the results of the third RCT for transcatheter edge-to-edge repair for aka MitraClip for functional MR in patients with heart failure with reduced ejection fraction. As you all know, MITRA-FR trial was stone cold negative, no difference. COAPT tier was almost as good as clean drinking water or antibiotics in bacterial infection. It was amazing. Now, these are 2 of the most opposite trials for the same condition I've ever seen in cardiology. Of course, proponents of the transcatheter edge-to-edge repair say that COAPT recruited the perfect patient. I wrote about this RESHAPE HF trial in the heart.org Medscape Cardiology. You can take a look at it. But anyways, finally, we get the results of RESHAPE HF, the third trial in this space. It was 500 patients with functional MR and LV systolic dysfunction. It was transcatheter edge-to-edge repair or medicines. There was no sham, so it's an open-label trial. The primary endpoint was... Wait. There were 3 primary endpoints. Not 1, 3. The first was the rate of the composite of first or recurrent hospitalizations for heart failure or CV deaths at 24 months. And that's a typical primary endpoint. The second was the rate of first or recurrent hospitalizations for heart failure at 24 months. And the third was the most dubious, the change from baseline to 12 months on the KCCQ questionnaire, quality of life, basically. Now, before I tell you anything about the results, just stop and think. Why do we have 3 endpoints? Why do we have a subjective endpoint in a trial where one group gets a big caring procedure with echoes and all these doctors at the procedure, and the other group gets plain old tablets? I'm sure you are thinking that the chance of RESHAPE being negative with these sorts of endpoints is pretty low. Indeed, RESHAPE HF was positive, not negative. At 2 years, the rate of CV death or heart failure hospitalization was 37 events per 100 patient years in a device arm versus 59 events per 100 patient years in the control group. That rate ratio was 0.64, so really effective. Confidence interval 0.48 to 0.85, so a very low p-value, highly statistically significant. In the second primary endpoint, first or recurrent hospitalizations for heart failure was also positive, hazard ratio 0.59 with very tight confidence intervals. The mean difference in KCCQ score over 1 year was 11 points higher in the device arm, and this too was clinically significant and statistically significant. There were more impressive risk reductions in the first primary endpoint were notable in subgroups with more severe heart failure, worse mitral regurgitation, higher effective regurgitant orifice area, and especially in patients who had been hospitalized for heart failure within a year before the randomization. And these, of course, were the results that made headlines. But let me just mention some of the endpoints that were less emphasized on social media and regular old news media. So first, despite the 20% absolute risk reduction in heart failure events, the device did not produce a statistically significant reduction in all-cause mortality, nor cardiovascular death, nor the rate of total hospitalizations for any cause. Nearly 1 in 5 patients died from cardiovascular causes, and yet the device, which reduced MR, reduced heart failure events, did not have an effect on CV death or all-cause death. In my column, I listed multiple reasons to be cautious about this trial. First, it took 8 years to recruit from 30 centers. So these were highly selected patients, and we should keep that in mind when we're picking patients who we might want to do transcatheter edge-to-edge repair. RESHAPE is an open-label trial. The 2 drivers of the positive endpoints were heart failure hospitalizations and KCCQ. Well, obviously, the KCCQ is susceptible to knowing your treatment assignment, and I wouldn't even have used it. It's kind of, I don't know, it's just kind of bad to be using quality of life in an open-label trial. They did it in Triluminate with the TriClip, and it's not right. But heart failure admissions is also susceptible, right? Because the decision to put a person in the hospital is a clinical decision. A human being has to make it. Knowing the treatment assignment may bias such a decision. This isn't nefarious, it's just clinical care. A patient with a clipped mitral valve who has fluid overload may be more likely to receive outpatient diuretic than a person without that bright right clip on their echocardiogram. All right, third caution. Why doesn't the MR treatment reduce heart outcomes? If the device is so great for people, these huge hazard ratio reductions, if it shreds heart failure hospitalizations, why doesn't it prolong life in these sick patients? That it doesn't affect hard endpoints strengthens the arguments for performance bias in the matter of hospital admissions, I think. Similar argument for all-cause hospitalizations. If the device is so great and it reduces heart failure, and these patients have serious heart failure, why don't we see a reduction in all-cause hospitalization? This, to me, speaks to the fact that many of these patients have competing causes of illness. Or, I guess, of course, it's also possible that the effect from the procedure is simply not that great. A technical concern with the trial is that there was differential loss to follow-up. Premature termination of the trial occurred in 41 patients in the control arm and 13 in the device arm. That's kind of curious. So, RESHAPE enrolled patients with less severe functional MR than the other trials. Some at the meeting and some online I saw suggested that we should use this trial to expand indications for transcatheter edge-to-edge repair. And I just want to say that I disagree strongly with that for the reasons I listed just now, plus the observation that the subgroups in RESHAPE showing the greatest benefit were those with more advanced MR, those with recent hospitalizations, those with larger effective regurgitant orifices areas. In sum, I think transcatheter edge-to-edge repair is a very nice innovation. Taking these trials together, I get the sense it helps some, perhaps few, patients with functional MR, and the challenge is, it seems to me, is choosing the most likely patients to benefit. Now, sadly, there are other factors that go into choosing when to do these patients. Here in the United States, some of these other factors are that A, doctors love doing procedures. B, doctors in hospitals are paid well for the procedures. And, of course, the more procedures a doctor does and bills for, the more status that doctor receives in the hospital system. So I hate to end this way, but we should mention that there are conflicts of interest that go into these decisions. But I think patient selection is going to be the key thing, and picking out patients most likely to benefit for transcatheter edge-to-edge repair in functional MR in heart failure. So that's it for this week in cardiology. As always, I'm grateful you listened, and this is only a small amount of the trials at ESC. In future podcasts, I'll have more trials to talk about, but I don't want to go on for more than 30 minutes each week. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.